Hello, everybody. I'm very happy to be here today to share with you some data regarding COVID-19 and the anti-inflammatory therapy. I'm Karine Lacombe, professor of medicine, specialist in infectious disease, and I work in Paris, Saint-Antoine Hospital, Sorbonne University. First of all, you can see here my declaration of interest updated on the 15th of December 2020. And just before I start with the treatment, I'd like to set up the scene by reminding you about the natural history of COVID-19. So you see here that COVID-19 is modeled on three stages. The first stage, which is early infection, which corresponds to the viral response phase, where obviously anti-inflammatory drugs are not indicated, and phase 2 and 3, which are pulmonary phase, where the heart inflammatory response phase starts, and then stage 3, which is in hyperinflammation phase. And anti-inflammatory drugs are really targeting those two phases here. You see on this very basic picture a summary of all the drugs which have been developed and repurposed to target the anti-inflammatory phase of the COVID-19 disease. And they really try to interfere with the inflammatory pathway, which is triggered during the cytokine storm that we see in severe COVID-19 forms of the disease. And I will really focus on three kinds of inflammatory drugs here, the interleukin-6 inhibitors, interleukin-1 inhibitors, and JAK inhibitors, which doesn't mean that the others could not be evaluated, but right now we do not have sufficient data supporting the use in routine care. And you will even see that for the anti-inflammatory drug that I will share with you, it's not still completely indicated in the current recommendations worldwide. So first of all, let's see the interleukin-6 inhibitors, and I would like to remind you of the brief mechanism of action of those inhibitors. So you see on the left side of the slide how the soluble interleukin-6 receptor can trigger the signal transduction, which leads to the inflammatory storm. And when you look at the right picture, that's where the anti-interleukin-6 receptor that inhibits the mechanism of action of interleukin-6 that blocks the signal transduction and calm in the inflammatory storm. So the most used drugs of this class is tocilizumab. Tocilizumab has been extensively used in internal medicine for years and years, and it has been repurposed at the drug that targets the interleukin-6 receptor and block some of the cytokine storm. So a lot of clinical trials and retrospective cohorts have been published, and I've decided to share with you the results reported in this meta-analysis because that's the only one which reports the results of the COVACTA, EMPACTA, and Corimino, TOSI, and BAC-BAY, and OCT, TCZ, COSI-19 clinical trials. 5 clinical trials to date have been indeed published. And you see here that the effect of tocilizumab of 28-30-day mortality in those 5 randomized trials is not proved to be significant. So no significance of effect on the mortality in those randomized trials. But there was no difference in risk of infections and adverse events when using the tocilizumab. That was one of the problems that we wanted to eliminate when using the tocilizumab. But regarding another effect of tocilizumab, this one on mechanical ventilation in randomized trial, you see that this effect is positive in favor of tocilizumab when you look at the effect. So there is a decrease in about 30% of the risk of mechanical ventilation in patients treated with tocilizumab compared with placebo, which is quite a good result. And when you look at the composite outcome, ventilation, mechanical ventilation, and death, this is here again positive, and this is clearly driven by the decrease of risk of mechanical ventilation. So a pretty positive result of tocilizumab reported in clinical trials regarding the risk of clinical progression. And here you've got the effect of tocilizumab on short-term mortality in that time moderately biased cohort, retrospective cohorts, and you see that this effect, this positive effect on short-term mortality has been reported in moderate to severe patients, severe critical, and critical, not really in critical and severe critical, but really mostly moderate, severe, and severe. This is a borderline effect, but also marked in severe critical and critical. So I will give you some of the conclusion regarding the tocilizumab use a little bit later on. So now if we switch to the JAK inhibitors, you've got here the brief mechanism of JAK inhibitors. You see that during the hyperinflammatory stage, there is an elevation in blood of a large panel of cytokines, including interleukin 1, interleukin 2, etc. And those cytokines activate the inflammatory stage through JAK1 or 2 receptors. And when you inhibit those receptors, there is a decrease in the inflammatory stage. So the first JAK inhibitor that has been a little bit more than others studied in the COVID-19 disease is baricitinib. And the fact that baricitinib has gone to phase 3 trial come from this observational study assessing baricitinib 4 milligrams BID for 2 days, followed by a QD dosage for 7 days, versus no baricitinib in patients hospitalized with COVID-19 pneumonia. And you see here that the effect of baricitinib was quite marked on death, but not an ARDS or median duration of hospitalization. So you see here the effect of on the decrease of some chemokines like interleukin 1b, interleukin 6, TNF alpha, but no effect on interleukin 8. So that was quite encouraging, and that's why trial has been designed evaluating baricitinib and Ramdesivir. That was a phase 3 trial. Remdesivir has been used as a standard of care because this trial has been designed just after the results from the first phase 3 Remdesivir trials have been released. And at that time, Remdesivir looked like it could be the new standard of care. So you see here this study that has been very recently published in the New England Journal of Medicine. That was a multi-center, adaptive, randomized, double-blind, placebo-controlled phase 3 trial, including more than 1,000 patients with the confirmed SARS-CoV-2 infections and the moderately severe patients randomized in 2 groups, baricitinib plus Remdesivir or placebo plus Remdesivir. The primary endpoint was time to recovery by day 29. And you see here that overall, there was a positive effect of baricitinib plus Remdesivir doing better than placebo plus Remdesivir. If we look in detail the results, you see that this positive result is mainly driven by patients treated in North America, but not in Europe and Asia. Here again, if you look at the age, it's been driven, the positive results is driven by the group of patients from 40 to less than 65 years old. Again here, mainly men, and here you see that it has been mainly seen in patients with a severe form of the disease. And here again, you see that in the ordinal score at baseline, it's mostly seen in patients with a score of 6, which means patients hospitalized with need of oxygen. So we are now waiting for more data on baricitinib, and especially baricitinib alone without remdesivir, because we now know that remdesivir should be prescribed during the antiviral phase, and baricitinib is more prescribed, could have its room in patients with inflammatory stage. Now, the third group of anti-inflammatory drugs that I would like to share with you, the interleukin-1 inhibitor, and mainly Anakinra. So Anakinra, there is no phase 3 trial published so far. So we've got data from retrospective analysis of severe forms of COVID-19. The first one has been published from patients in France, and the second one I will show you in the next slide has been published on patients in Italy. And you see here that in this retrospective analysis of a small group of patients, and the Anakinra group, 52 patients, historical group, 44 patients, we see that there is a positive effect of Anakinra on the probability of event-free survival, like death or invasive mechanical ventilation in ICU, or death or invasive mechanical ventilation in ICU. So Anakinra in this retrospective analysis have prevented the progression to ICU, ventilation, or death. In this second study, retrospective analysis of ARDS on non-invasive ventilation patients due to COVID-19 from Italy, here again, the survival and mechanical ventilation free survival at 21 days was better in the group treated with Anakinra compared to the placebo group. So some of my take-home messages regarding the activity of those anti-inflammatory drugs. I have to say that so far, very few of those drugs have reached phase 3 trials, and no anti-inflammatory drugs have been better than corticosteroids in reducing the risk of clinical progression. Probably timing matters. It should be administered neither too early or too late. And you see that, for example, with baricitinib, the data we have is really into the middle in patients with no real viral stage anymore, but no too severe inflammatory stage. Tocilizumab has been quite extensively evaluated so far with two very big trials called Impacta and Covacta with mitigated results, and some smaller trials with better results. So there is no clear-cut answer about the room to give to tocilizumab in COVID-19 disease. It tends to have a positive effect on clinical progression in clinical randomized trial and a positive effect on mortality in retrospective cohorts. And Anakinra, we are still waiting for RCTs, and it tends to be efficient in preventing clinical progression in retrospective cohorts. And baricitinib, we are also waiting for RCTs outside association of Ramdesivir. So I have to say that to conclude on those take-home messages, that we need to go on with the evaluation of anti-inflammatory drugs, because it's not because we are entering the vaccination era, but unfortunately patients will still get the disease and will still arrive at hospital with a severe case of COVID-19, and at that stage specifically, so far only anti-inflammatory drugs or look like they're going to work. And I would like to say thank you, merci to everybody. So you see me at the right corner, right into the management of the epidemic. And I wanted to thank you, all the colleagues I've been working with for those last 8 months at the heart of the pandemic. Thank you very much for your attention.